Classmates and professor, my name is Sierra Bergeron. In this video, I am going to be discussing two case scenarios. First, I am going to share my response and rationale for case number 1. To begin with, for a physician to affirm the diagnosis of an individual that presents like various different health conditions, a differential diagnosis must be performed. A differential diagnosis refers to the process of determining between two or more possible conditions which share similar signs or symptoms. In order for this to occur, there has to be evidence of a specific clinical feature or features that can rule out one disorder from the others. In this case, I had to compare and contrast between the urea cycle disorder and disorder of beta oxidation. Through extensive research, I have found that the key diagnostic to differentiate the given metabolic disorders is to determine the plasma glutamine level. Evidence has shown that glutamine can become a noxious agent to the brain. The excess glutamine production can compartmentalize ammonia metabolism, which ultimately leads to swelling and inflammation of the brain and high levels of ammonia in the body. Glutamine can be one to blame because some ammonia produced in the body is derived from glutamine metabolism. When glutamine is metabolized in the brain cell's mitochondria by phosphate-activated glutaminase, it will yield glutamate and ammonia. Glutamine and ammonia have a direct relationship, which explains why they both would be elevated. The other answer choices are incorrect for several reasons. Depending on the feeding status of the infant, meaning the time and quantity of her last meal, the blood glucose and fatty acid levels could be significantly higher or lower. It is possible that she could have consumed a meal right before seeing the physician, or her body could have been in a fasting state due to poor nutritional intake. Hence, these two blood levels cannot confirm the diagnosis of the individual because they are much too generalized and can vary at any given time. When reviewing the urinary acids excreted, likely the results are also not able to define the individual's condition. Urinary acids can be a good indicator for finding out a metabolic dysfunction. The urine sample can reveal a range of organic acids, such as ketonuria, orotic acid urea, and more. However, they are not always consistently present in the individual, which makes this diagnostic marker to be unreliable and inconsistent. In summary, the plasma glutamine level, along with the full lab workup, are going to be the most consistent findings to lead the physician to the definitive diagnosis of a urea cycle disorder. More specifically, an OTC deficiency. Furthermore, OTC is a rare disorder characterized by a lack of the enzyme OTC. In this patient, where the orotic acid levels are elevated, one of the urea cycle enzymes that will be deficient is the OTC. Orotic acid levels can distinguish whether the individual has OTC deficiency or CPS1 deficiency. Therefore, an elevated orotic acid level can confirm OTC deficiency, while the CPS1 enzyme is least likely to be impaired. Conversely, the opposite can also be applied. When orotic acid levels are low, you will see an impairment of the CPS enzyme, but no impairment in the OTC enzyme. Okay, I am now going to share my response for the next case. So, the best explanation for the presentation of gout in this individual is related to the decrease in urinary excretion of uric acid. The individual's laboratory results correlate because it shows the lack of uric acid being excreted through the urine, in which the plasma urate circulating in the bloodstream significantly increases because it has nowhere to be excreted. To link these signs to a root cause, I think the individual should first and foremost stop drinking soda and see if this diet modification can help treat or cure the gout. Secondly, I think there needs to be further diagnostics for other possible contributing risk factors, including hypertension, diabetes, impaired kidney function, i.e., serum creatinine, BUN, and glomerular filtration rate levels, and even certain medications. Now, I will explain why a decrease in salvage of purines and also overproduction of purines is inconsistent with the given data. When an individual has a deficiency in the purine salvage pathway, there are specific enzymes that are defective and considered to be a rare genetic mutation. One of the rare disorders caused by this decrease in salvage of purines is also known as Lesch-Nyhan syndrome. The individual normally presents with severe central nervous system dysfunction, CNS dysfunction, such as intellectual disability, dystonia, and even self-mutilation. Also, an overproduction of purines can be described as a purine nucleotide synthesis disorder. For example, one of the disorders is called PRPS1, which is a superactivity of a synthetase enzyme. I'm not going to say the whole thing. PRPS1 helps produce PRPP, which is one of the molecules involved in purine production. That being said, there's an increase, and the clinical characteristics onset is as late as early adulthood, and it can be mild type to severe type. The mild type consists of uric acid, crystalluria, and urinary stones. And the severe type can bring about CNS dysfunction such as hypotonia, hearing loss, and ataxia. Overall, it is likely that the individual's current health condition cannot be caused by these two options because of the genetic component and also how these mutated genes are expressed at a young age along with serious CNS complications. In regards to the individual's diet modifications, switching from diet soda to regular soda will have a potential negative impact. Since regular soda contains high fructose corn syrup, the fructose must be metabolized in the body. When fructose is broken down, the liver responds by depleting hepatic adenosine triphosphate, ATP. When the ATP is used up, adenosine monophosphate accumulates while simultaneously stimulating ATP deaminase. This process initiates the production of uric acid. Altogether, it would be most beneficial for the individual to continue drinking diet soda or no soda at all rather than regular soda, and further investigate for other potential comorbidities and risk factors that are leading to the gout. All right, thank you guys for watching.